Is my audio coming through clearly?
Yes, doctor. The audio is okay.
Great.
We are recording right now.
First of all, let me start by thanking the Peruvian Society of Cardiology for inviting me to this meeting. On behalf of STEMI India and the Global Stent Save a Life organization, I would like to thank each one of you for this opportunity, and we look forward to working with Peru in developing a STEMI system of care. So today what I will do is over the next 20 minutes, talk to you about the management strategies for STEMI in low and middle income countries and use the experience from the TN STEMI program to do that. Now, looking just very briefly at what is the current state of affairs in India, and this is from the Lancet, which looked at India's health of the nation states. And you can see that epidemiological transition from communicable diseases to non-communicable diseases has taken place across the country. And this occurred in the early part of 2010, when even the poorly developed states have taken this epidemiological transition. And if you were to look at the leading causes of death, you can see that in 1990, it was some of these infectious diseases, neonatal disorders, lower respiratory infections. But by 2017, ischemic heart disease was #1. And if you're looking at early death, look at 2016, it's ischemic heart disease and stroke. And all the way, if you were to project that up to 2040, you will see that ischemic heart disease and stroke will continue to remain the major causes of death, and we need to tackle this. So today's agenda, I will look at the TN STEMI program. We'll look at challenges in STEMI management, the benefits of a STEMI system of care, the infrastructure appropriate variations of the hub and spoke model, how do we implement the STEMI India model, and look at some of the global programs. So let's first look at the TN STEMI program. Now, when we started this program, we were clear that there were two very good reperfusion strategies, the pharmacoinvasive and the primary PCI. So we devised a hub and spoke model. So if a patient presented to the hub hospital, he would get primary PCI, while if he presented to the spoke hospitals, he would first be thrombolyzed and then move within 2 to 24 hours to the hub hospital for pharmacoinvasive treatment. The results of this study was published in JAMA Cardiology 3 years ago. And what we were able to clearly show was there was a 3.4% absolute mortality reduction within 9 months of setting up this program. And we also did a cost benefit calculation, and this was done with one of the premier health economists of the country. And we were able to show that for every rupee that was spent in this program, there was a 3.58 economic benefit to the country. The result of this, that this was then accepted by the Indian Council of Medical Research and became a national health program. And at the current time, there are about 4 to 5 states which are currently implementing this program, while many other states are in different stages of implementation. So what the project was successful at the individual level, we were able to bring about a 3.4% mortality reduction within just 9 months of starting implementation of the project. And that is a relative mortality benefit of something like 19%. At the institutional level, we were able to change practice dramatically. 46% was the primary PC and pharmacoinvasive rates before we started the program. We were able in just 9 months to take it up to 63%. And this, we believe, is the real reason why we were able to get very, very early benefits. And there was, of course, considerable capacity building for staff at the spokes. Training took place. And at the society level, there was a clear cost benefit. So the outcomes of the study showed that there was a reduction in patient mortality. There was an increase in patients with chest pain appearing in many of these both spokes and hub hospitals, so that many of the delays of door in and door out of patients going to non-STEMI hospitals was taken care of. There were better data and analytics, so we were able to pick up gaps in implementation and help to improve that. Many of these hospitals, which were now reperfusion centers, were accredited so that patients and the people in the neighborhood knew that these were the hospitals to go for if you had chest pain. The emergency medical services, which were part of this program, improved. And of course, there was work on patient awareness in the geographies where we drove this program. So the 5 key aspects of the success of the program was there was a dedicated agency for project implementation. And at this, in many of our developing countries, I think this is critical because there are multiple players who need to be to work together to get a program like this in place. And unless you have a dedicated agency which is coordinating this whole program, it is difficult for it to work. Collaboration with government, and I think this is true of every developing country. You cannot run a program like this without government being a partner in this. And we insist on that. Wherever we've run this program, we want the government to be part of it. Part of the reason being that the emergency services, public hospitals are all part of the government. So it is important that they are part of the program. Now, integrating the hardware and the software, including tele-ECG services, and this is, I think, critical. Using some of these digital tools, we were able to overcome some of the big deficiencies in both infrastructure as well as in terms of trained manpower. Partnership with the ambulance network, again, is critical in a time-sensitive disease like this. But I think I would draw your attention to the statewide insurance scheme. So I think one of the successes of this was that we had the government-run insurance scheme as a partner in this program, so that every patient, irrespective of their paying capability, who came into the system was able to get all the reperfusion therapy. And I think these 5, I think, very, very important aspects need to be kept in mind when we run a program in any developing country. The results of this program and multiple issues with how to run the program have been published in very, very prestigious journals across the world. This is the British Heart, BMJ Open, Global Heart, Indian Heart Journal, JAMA Cardiology, Circulation, and Asia Intervention. Let's look at challenges in STEMI management. Now, I think it's important first when we run a program to understand what is the estimate of the number of cases of STEMI in our country. You have data from the US, you have data from Europe. If you look at India's data, and again, it's a little bit of a guesstimate, not really a true number. We estimate that there are 2,000 per million MIs in our country, and that, looking at the population, we would have something like 2.4 million MI per year. And we have something like a 60% of ACS patients presenting with STEMI. So somewhere in the ballpark range of 1.5 to 1.75 million STEMI patients a year. Now, if you look at some of the registries in India, the CREATE and the Kerala ACS registries, you will see that about 50 to 60% of patients get reperfusion therapy. But if you go to more rural communities, you actually see that it's close to only 35% who get reperfusion therapy. And therefore, I think this is a huge problem. And if you look at countries in Africa and probably even in Peru, you will see in the rural communities, reperfusion therapy is very, very poorly served. And what happens to these patients who don't get reperfusion? If you look at some of the data and you extrapolate, we have 100 untreated patients, only 60 will leave hospital alive. By 1 year, it comes down to 50, by 5 years, 30, and by 10 years, only 15 of them will be alive. And I think we have to realize the gravity of this. The other area that I would call your attention to is the patients by age. I think in many of the developing countries, a large proportion of STEMI occur in young patients. In India, this is different states. We're between 20 and 25% of our MI in less than 45 years of age. And this obviously has a huge socioeconomic impact. If you look at treatment and look at the analysis by whether they are rich, upper middle class, or lower middle class, you can see that primary PCI, coronary angiography, invasive therapy is seldom used in the poor patients, and that's reflected in the increased mortality that you see in this patient. Therefore, when we start a program, we need to make sure that there is equity and make sure that the poorest of the poor have access to this care. What is the benefit of the STEMI system of care? There's a better treatment strategies, and we showed this again in the TN STEMI program. If you looked at standalone thrombolysis and looked at mortality, it's close to about 9%. This is in hospital mortality. But if you used primary PCI or pharmacoinvasive therapy, came down to 2%. So clearly, the pharmacoinvasive and primary PCI strategies are far superior. If you look at data from one of the states, you can see that standalone thrombolysis of 53% came down to 29%, and the primary PCI and pharmacoinvasive went up to about 60%. If you look at Gujarat again, you can see 43% down to 30%, that's standalone thrombolysis, and you can see the primary PCI and pharmacoinvasive with the implementation of the program went up significantly. Look at no treatment in another state, came down from 28% to 13%. So if you look at different states, if they are depending on their state of development, on the facilities they have, every parameter that impacts on outcomes can be improved. If you look at mortality, again, this is the Tamil Nadu data, which showed a 3.4% mortality reduction. If you look at Punjab, there was almost a 100% mortality reduction. So why is the STEMI India model work? It uses existing resources by setting systems in place. It equips field staff and enables sustainability in the long run through continuous training. There's a flexibility in the different strategies that we adapt. One model might move to another model as infrastructure improves, as training improves, and these are modular and scalable across different geographies. When we talk about infrastructure appropriate variations of the hub and spoke model, what do we mean? Now, if you look at very rural places where no reperfusion is the norm, and I showed you one state where only 35% of the population has reperfusion therapy, what we advise is first a model one, where we say, let's get the hospitals to start thrombolysis at least. So we supply a third generation lighting. We train these smaller hospitals. We may help them with remote diagnosis or a tele-ECG facility, but they get referred only if there is, say, hemodynamic or electrical abnormalities or for failed thrombolysis. So this is the thrombolysis alone model, may be supported by tele-ECG, and in some places, we even have tele-CCU support. So this is really in very rural communities where there's no cath lab available within reasonable driving distances, and even any mode of reperfusion would be an improvement as compared to no reperfusion. Model 2 is where there is a cath lab available, and this is the standard hub and spoke model where we have a reasonable, we have a hub hospital within reasonable driving distance. So you have primary PCI in the hub, and you have pharmacoinvasive in the spoke. So this is linked together in what we call a STEMI cluster, so that there is communication between these. And these linkages are built on electronic data communication, management protocol, insurance reimbursement is built into this, so that you have to do this to get insurance reimbursement, and there is a dedicated EMS network which works with them. The third model is, of course, in very urban areas, and these are in our own country, in urban situations, we look at a primary PCI program so that There are multiple cath labs available for the patients to go either directly, or if they go to smaller clinics, an ECG is done, STEMI confirmed, and then moved to the hub hospital for primary PCI, like in the Western population. So these are the three models. And as I emphasized, one can move to the other as infrastructure improves and as training improves. How do we implement this? And I think there are two major components. Now, when we talk about a STEMI system of care, remember, you need to integrate the ambulance service with some hardware, software that works. I'll show you some of the digital tools that we have. ECG diagnosis, tele-ECG is often required, especially in rural population. Protocols have to be built. Training has to take place, and that has to be recurrent. Analytics and gap analysis, and there should be a governance that we make sure that a government is also part of this governing body. So there are two aspects which we emphasize. One is the clinical management at STEMI, and the second is setting up the system of care. And the clinical part includes diagnosis, emergency care, treatment strategy, training on medications, dosages, while the core program of setting up the system is setting up the clusters, monitoring key quality parameters, and a periodic gap analysis so that outcomes can be improved. A word about the digital tools that we use. One is an app that can be downloaded in the geographies where we run these programs, and this is for the patient. It talks about the heart attack symptoms. It gives you data on the medications that they're on, exercise programs, stress, smoking. But it also does an important thing that it picks up the closest STEMI accredited hospital by GPS, closest to a patient who has chest pain, so that they don't waste their time going to another hospital. The second digital tool we talk about is an ECG machine, which has transmission capability. And in areas where an older ECG machine is available, we have an app using a smartphone which can transmit these ECGs. And these are very secure apps. And the ECG can be transmitted to either a tele-ECG service or to the hub hospital where a cardiologist can interpret the ECG. The third is the data collection itself. And this is something that we insist on so that you can do gap analysis and you can make sure that your quality parameters are met. And if they're not met, we work with these hospitals to improve them. And lastly is the dashboard, which gives you a real-time information about patient recruitment, about patients' results, so that they, at one glance, each hospital can see how they're doing. Finally, a word about the global programs. STEMI India is working, has signed an MOU with the Stent Save a Life, and together we hope to bring many of these tools that STEMI India has used in its program to countries globally who are partners of Stent Save a Life. Now, this is the central office. Jan Peek from Netherlands, myself and Sandrine are part of the central office. We have an advisory board of the who's who of European Society of Cardiology, with ambassadors who work with us. And each of the continents have champions who are working with countries in their region to help other countries to become members of this program, as well as how to run a program. How do we choose a country to run a project? We look for strong local leadership and broad acceptability across the country. We look for strong ties with local government and ambulance services. Reperfusion therapy and ambulance services, we prefer that to be funded by government or insurance. Funding of local project and personnel have to be taken care of by the local host SSL, but the global SSL would provide the tools, the digital tools, the modalities, and the periodic reports that will go to each of these countries as they run the pilot projects. I would encourage you to look at 3 papers. This is how to set up a regional STEMI network. This was published in Euro Intervention. This is a circulation white paper. Again, a very, very useful paper that looks at resource and infrastructure appropriate management of STEMI in low and middle income countries. And again, an Asia intervention paper where I've summarized the Tamil Nadu ST elevation program and how learnings from that can be used in low and middle income countries. So thank you once again, and I hope sooner rather than later, we will be able to work together with the Peru Cardiology Society to develop a STEMI system of care that is appropriate for your country. Thank you. Dr. Lopez.
Thank you, doctor. Please let me see if